All right, let's talk about Florida demographics and characteristics. And the moral of the story here, again, is that racial and ethnic disparities persist and the young are not immune. This is a slide that I showed at our last presentation. So this was current as of July 22nd. And at that point, there were 5,200 deaths on the night that I presented, and the projection, which is a model that comes out of the University of Washington, and it is really one of the most accurate models all along in the last 8 months, projected anywhere from 12 to 19,000 deaths by November 1st. And I said at that time, let's assume somewhere in the middle, about 16,000 deaths. Well, we reached 16,000 deaths this week. And that's just a couple weeks early, but it shows that this model is really quite accurate. At the time, I took the percentage of deaths based upon the first 4 months or 5 months of data and projected out what we might see in different age categories here in Florida. Luckily, our percentage of deaths in the younger age groups is lower than what it was initially. Now remember that when I presented this on July 22nd, this is an important point, we were just coming down from our summer peak. Remember, we had taken that steep climb up and we were just beginning to come down the backside of the mountain. So we had already reached max for July. But young people, not as bad. Here, however, we have seen an increase in the 45 to 64-year-old age range as far as percentage of deaths. And then over age 65, it's about the same, a little bit, 1% less, but about the same. If we look at, take a more granular look at the age groups here in Florida. Here in this column is July 22nd. So these were the numbers when I presented 3 months ago, and the right column is from yesterday, essentially. And you can see that in our 0 to 14 age range, we've gone up in all the groups, 2 to a little over twofold. Our hospitalization rate in our 0 to 14 age group is triple. So the hospitalizations went up a little. Death rate is 2.5 times what it was in July, the last time I presented. This is compared to July. Our ages 15 to 24 are about double, maybe a little more than double in deaths. Our ages 25 to 54 are double to 2.7 times more in deaths. And our ages 55 to 84 are double and triple in deaths. So we have clearly gone up, and this is at a time when we actually were coming down. But the numbers are still going up fairly well. The last presentation, I talked about the pediatric multisystem inflammatory syndrome, which is a scary disease that we see in some children who are sick with COVID. And again, the scary thing about this illness, certainly it has a mortality rate, but these children can go into shock and cardiac arrest and respiratory arrest. And the concern is that they might have heart damage because they look for all the world like a disease called Kawasaki disease, in which case we look for aortic aneurysms in these babies. Well, in July, we had a total of 14 cases. Look where we are today. As of yesterday, 69 cases in Florida, which you're not hearing talked about too much. That's a 5-fold increase just since over the last 3 months. It actually does include 1 case from Santa Rosa County. The average age is 8. And again, the racial disparities persist. 46% of these children are Hispanic, 41% Black. And of course, we don't know yet what the long-term sequelae will be. We'll have to follow this along in time. Infectiousness factors, what's changed? The moral of the story here is we are filling in knowledge gaps. If you remember 3 months ago when I presented, one of the major reasons behind why this disease is so infectious is the long incubation period before symptoms develop, up to 14 days. But the high percentage, around 40% we think, of infections that are asymptomatic or pre-symptomatic. And we know that infectiousness is associated with what we call the 3 C's, the close contact, the crowded places, the closed indoor spaces, and I always add in the 4th C, which is continuous exposure, or essentially time. Well, researchers have started looking at asymptomatic cases because why is there such a high percentage of these cases in a disease that has such a high mortality rate? I mean, what gives? Are they protected in some way from severe disease? So we've certainly had some researchers start to look at this, and there was a surprising blood bank study this summer where researchers from University of California, San Francisco looked at blood bank donors from 2015 to 2018. So a year and a half, 2 years before COVID ever reached us, they looked at blood bank donors, blood. And they found that in 40 to 60% of these old blood samples, when these blood samples were presented with COVID, the T cells recognized the COVID virus and they jumped into their immune fighter response. And you say, well, wow, how could this happen given that this virus is brand new? So that's fascinating. And they started to think, well, what are the possible explanations for this? Is there cross protection with other vaccines? Because we have seen this phenomenon with other diseases for many decades. Influenza is reduced in those who receive typhoid vaccines. Deaths from unrelated diseases are reduced in children who receive measles vaccines. And there are other kinds of examples. But a Mayo study this year found that people who received the pneumonia vaccine in the recent past had a 28% reduction in COVID-19 risk compared to those patients who didn't receive the pneumonia vaccine. Those who received polio vaccines had a 43% reduction in their risk for COVID. So first of all, I think, and tell you, please go out and get your flu and pneumonia vaccines if you haven't done it this year, because it actually may help protect you against COVID, even though it's not a vaccine for COVID. It may have this overlapping partial immunity feature, but this also may explain, you know, if there's protection from previous encounters with other viruses. So researchers have started saying, you know, why do children and young adults get so less seriously ill with COVID? Well, we know children and young adults are literally little germ generators, and babies and children in particular have common colds all the time. Maybe they have partial immunity from being sick more. Again, we have a long way to go before we know for sure, but it's fascinating hypotheses. And as I say, time to get the flu and pneumonia shots if you haven't. Now here is the role of masks in reducing viral load. This one just tickles me. I'm just so happy about this finding, and it makes sense to me. A California physician researcher noted that in settings with the highest percentage of asymptomatic cases, people were wearing masks. So a few examples that she looked at was an Argentine cruise ship where masks were given to all passengers and crew, and of the 58% infected, 81% were asymptomatic. San Francisco has a high percent of people who wear masks, and while cases have gone up there, there have been more asymptomatic people and the death rate has remained flat. A fish processing plant in Oregon issued masks to all workers, and while 33% tested positive, 95% of those who were positive were asymptomatic. And she has many more examples like this. She also referenced a study in hamsters, a study that we can't do in humans because it's unethical, where masks were used to filter COVID air into the hamster cages. And they were, first of all, less likely to become infected when they wore masks. And if they got infected, they had milder disease. So this brings us to this equation that I presented at the last presentation, where I said the risk of COVID infection is a function of viral load and exposure time. I think that we're getting to the point where we can say the risk of COVID infection and severity of infection is a function of viral load and exposure time. And what this means is that if you look at yourself as a healthy person with a mask, and you're around some idiot not wearing their mask, previously we thought it's still that you're at risk of getting infected. That's true. That hasn't changed. But do we stand a greater chance of asymptomatic or mild disease? Some of the data is beginning to show that that's true, and we do think that that's playing a role in the lower death rates in the disease as well over time. So I think we should take heart in this when we go into Publix and we see people without masks, instead of just simmering in anger over the fact that they're not wearing masks, give it up. And you know, granted, it'd be nice if they were wearing masks, because this would be really where you are. If both of you are wearing masks, you're protecting each other. But you are reducing, we believe you are reducing your risk of serious disease and death by wearing a mask. So that's all good news about masking. And speaking of masks, a recent Duke study looked at which masks are the best in reducing speech droplets. And no surprise, they found that the medical N95 was the best, but a better mask, not as good as the N95, but pretty good, were the 3-layer surgical masks and the 3-layer fabric masks. And moderately good were other single and double layer cloth masks, depending on the fit and the gaps. And of course, you all have worn masks long enough now to know a lot of it depends upon, you know, what kind of whether you have something at the nose you can press down and keep it closer to your face, and how it's fitting at the cheeks, things like that do make a difference. The worst masks were t-shirt knit masks and valved masks without filters, and bandanas, which they said were basically useless. But they found the worst masks of all were those stretchy, thin neck gaiters. And you see a lot of athletes wear these. You see a lot of coaches on the sidelines of the football games wearing these. They found that they dispersed the large droplets into small droplets, and then those become more easily airborne, which is why they found them to be the worst type of mask. That's only those that are really stretchy and thin and you know, almost see-through like, because a lot of the neck gaiter companies came back and really cried foul on this study, but it was a specific kind of neck gaiter. All right, let's look at Florida and Escambia County as of today or yesterday. This is Florida's curve, and again, July 22nd is where I last talked to you, and we were just starting down that mountain. And here we are on October 21st, and you can see that there's just a slight incline, we think. We're going to have to see whether it proves true. It's certainly not the kind of steep slope that the rest of the U.S. has seen in the upper Midwest, but there's almost no doubt that we're starting to see another increase. Hospitalizations are usually 2 weeks behind the diagnoses, and it's hard to tell whether this is an increase or not. It could just be that it's the same. We'll just have to follow it along. And the fatality rate here in Florida has been pretty stable, but again, fatalities are a definite lagging indicator. They come about a month after diagnosis, and so any kind of little increase we might be seeing in Florida, we really aren't seeing in the death rate yet. One of the areas that we like to follow are the influenza-like illness and COVID-like illness diagnoses that come out of our emergency rooms. It really is like the canary in the coal mine kind of data to look at. And this blue curve on top is the COVID-like illness presenting to the emergency rooms. And this is current as of this week. And the orange line is the influenza-like illness. Now, first of all, I want to say we have already clearly started into influenza. So if people get sick around you, if you start in with a fever, chills, body aches, in fact, I have several close friends, including a neighbor who just went through this, got tested for COVID, and it's the flu. So we are starting to see the flu, but it does look like we're starting to see it go up in conjunction with COVID as well. So winter, as they've been saying, is going to be tough. These are Escambia County numbers in comparison from yesterday to 3 months ago. Cases have doubled. The average age is maybe from 39 to 44 years old over the last 3 months, so a few years older, not that big of a difference. Hospitalizations, however, in Escambia County tripled over the last 3 months, and the deaths quadrupled, and long-term care cases doubled. Now, part of that is that Escambia County already had a lot of long-term care cases heading into July 22nd. As you know, in the beginning of the pandemic in Escambia County, that's where a lot of the county was hit, was in the nursing homes. But it has doubled in the last 3 months. Correctional facility cases are up 20-fold. So that's been a terrible place to get COVID. The test positivity based upon the Florida Department of Health data was 12.4% in July. And again, we were just coming down from that surge, and it's reported now at 3.8%. So there are asterisks here because I want to talk to you about the test positivity and how it differs in Florida and in comparison to what other institutions calculate for our positivity. The good news is this: if you use the Florida Department of Health rates, all you want to do is look at trending. That's fine. Just stick with it and look at the trend. But the problem comes when you're trying to determine that 5% mark. And we'll talk about that in a minute. This is the age breakdown in Escambia County from July. These were the numbers when I talked to you in July, and these are the numbers over the last couple of days. In our less than 14-year-old children, we've doubled the cases. Our hospitalization rate in Escambia County went up 5 times. That's much higher than the Florida rate. So our children were hospitalized at a higher rate in Escambia County. No deaths, no more deaths. So we have 0 deaths in that age group, and we have 0 deaths in the 15 to 24 age group in Escambia County. That's all good. In the 15 to 20, our college age, high school college age is essentially doubled in cases and hospitalizations. Our young adult to middle-aged adult, 25 to 54, doubled in cases, up 2.4 times in hospitalizations, and up tripled in deaths. Florida death rate went up about 2.7, so a little bit higher than the Florida death rate in this age group. And then in the age 55 to 84-year-old group, we little more than doubled cases in the last 3 months. Our hospitalizations tripled compared to Florida's. Oh, shoot. Let me go back here. Tripled compared to Florida's doubling, essentially, and our death rate in the 55 to 84-year-old group went up over 5 times compared to Florida's tripling. So we do have some statistics here in Escambia County that are much worse than the Florida numbers. All right, so testing and percent positivity. This is still a work in progress. I do want to review the kinds of tests that are available. the PCR or polymerase chain reaction test is still what we have to consider the gold standard, even though it's more like a bronze standard. It's not great, but it's the best we've got. You can get your results up to 2 days. This is, you know, the deep nasal oral swab. The problem, of course, over the summer was that it was taking 2 weeks to get results back, but it should take only 2 days. And I know my next door neighbor who just got tested a couple days ago, it only took 2 days to get her result back. The problem with the PCR test is it is reliable in the first week of disease only. So you can't go 2 weeks later and get one, or and even too early in the course of the disease, when you may not know that you have it yet, it may not be positive, but it's the best that we've got. Now, the good news is that there was a new PCR test, a saliva PCR test that was just approved by the FDA in August. It's a saliva test, so they don't have to do the Roto-Rooter up the nose test, which is good. It's cheap. It's less than $10 and it provides rapid results within a few hours. It's good because it depends on using common equipment that you don't have to depend upon complicated supply chains for. So for example, it uses regular Q-tip swabs from CVS or Walgreens. You don't have to buy special ones, order special ones from China or something. It doesn't require skilled personnel to conduct or run the test. And it is considered that it will be a game changer for low-cost mass testing at work sites and schools and long-term care facilities. I am not aware that we are using this here locally, and I really hope that we start at some point because this seems like a wonderful PCR test. In the meantime, when you hear people talk about rapid tests, having rapid tests available here, they're talking about antigen tests. These are tests that look at the surface proteins of the COVID virus as opposed to its RNA. It's a nasal test, takes up to 30 minutes to get results. The problem with the rapid test is that there's a lot of false negatives. The test can be negative when the amount of antigen is low. Typically, if it's positive, it's usually pretty good. And if you're having symptoms, your antigen material is probably at its highest, and it's probably pretty accurate when you are, a couple days into your symptoms. Serology are the antibody tests. These have not improved any. I would not recommend getting them. Unfortunately, there are many places around town that market these tests as finding out if you have COVID, charge you $75, and they really are not that helpful. So what we really need is we need better PCR tests that are faster as far as getting results. Once that happens, we will be doing well, but we're not quite there yet. All right, let's talk about this test percent positivity, which theoretically is a simple calculation of positive daily tests divided by the total number of daily positive and negative tests. Seems simple enough. And it's traditionally been considered one of the best ways to determine how much the coronavirus has spread in a community and whether enough testing is being done. The goal has been to be less than 5% for 2 weeks in order to reopen society. Unfortunately, again, so much with this disease has been politicized, and that has been thrown under the bus. And we'll talk a little bit more about that. But ideally, this test percent positivity, the calculation should not include any antibody test results. It should be based on PCR results and not the rapid test antigen test results. It should be based on individual people who were tested and not on number of tests, because individual people can have multiple negative tests. And it should be based on consistent daily test reporting, not inconsistent data dumps. But unfortunately, we don't live in an ideal world, and so many states and countries don't track people. They only track test numbers. Many states and countries include antigen test results in their calculations, including Florida. And most states have inconsistent dumping of test data that does require us to use calculations of rolling daily averages. And that includes Florida as well. In fact, I think just today, a dump came in of well over 5,000 positives. And, you know, we just have to look at 7 days average just to kind of even things out a little bit. So what happens is that we see different calculation methods that are used, especially when trying to standardize and compare different states and globally different regions. The Johns Hopkins University COVID tracking project is considered to be one of the most reliable, especially here in the United States, because it looks at all the states, it compares states. And it measures how many people test positive on a given day for the first time out of all people tested in the state for the first time on that day. So it's a nice kind of pure test result. The World Health Organization also does their own calculation, but of course it looks mostly at the difference between and among countries. It measures the number of positive tests compared with the total number of tests in one day. So a crude number, but I can see one where you definitely would use something like that when you're looking at you know, different parts of the world, especially very remote areas of the world. Of course, Florida doesn't use either one of those methods. It uses two different methods. One is done by the Florida Department of Emergency Management. This includes people with the PCR and antigen test results daily. The antigen results were added just in July to their test results. And the problem with that is it does tend to skew the positivity rate lower due to all the false negative rates that come with the antigen results. A person is only counted once for each day, regardless of the number of test results received that day, and the positive result is the one counted if positive and negative results are received. So that's good. This part is really good. But it includes people who have tested positive in the past. So it doesn't give a good representation of new community cases. And Florida has decided they do not use this for the county rate. So the county rate that I just gave you for Escambia County, where we went from 12% down to 3%, this method is not being used. The method that is being used in counties is from the Department of Health. And what they do is they use the number of people who test positive, again by PCR or antigen test for the first time, divided by all the people tested that day, including those with prior negative tests, but excluding people who previously tested positive. Now, the high number of prior negative tests in the denominator is skewing the positivity rate downward, especially when you have to do the rolling 7-day averages. So you keep using multiple negative tests over and over and over to calculate your 7-day average. So this method is very controversial. It's criticized by many scientists who think it's junky, and it's rarely used, if at all, by others. And you therefore can't compare Florida to other states. So when they say we're under 5%, it really is disingenuous because nobody else uses the methodology that Florida uses. And it is the one being used in the county rates in the Department of Health reports. It is the method that is publicized by Florida and touted by the governor in order to open to phase 3 because it does yield the lowest positive rates. And I'll show you here in this graph, which is quite enlightening. The red graph on top is the Johns Hopkins University graph, the one that can compare us to other states. The orange graph is the Department of Emergency Management calculation. And the blue graph is the Department of Health calculation. Now, just looking several days ago on October 20th, or for 7-day rolling averages, the Johns Hopkins University calculation for Florida was 12%. At the same time that Florida was out there touting our 5.1%, which actually was lower than that, as you can see, a couple days ago, but we are slowly going up. The percentages definitely are going up. But it's close to 5% when in fact it's more than double that according to the Johns Hopkins calculation. And this shows, and this is a really good website to look and compare states, but here you see Florida. You see that it's 12% positive. We are going up. They're able to show us that. We're well above their 5% dotted line here. And when you compare us to Georgia, so they're using the same methodology. Georgia is at half our rate, Hawaii 2.5%. Idaho, as we've been hearing on the news, is 28.7%. They are part of that driving the increase in the upper Midwest and upper West. Illinois is at 5.5%. So Florida is still quite high compared to other states. And it probably is because if you look here, we still need to be doing a lot more testing. When you do more testing, you can drive the positivity rate down. We're not doing enough testing. 1.1 tests per 1,000 people. And if you look at Hawaii, for example, they're double the number of tests. Georgia, which still has a little bit of a high positivity rate, has more testing. So Florida needs to do more testing. And, you know, just again, watch the numbers coming out to know exactly what the percent positivity is. Again, follow one curve if you just want to look at trends, but if you definitely want to understand where we are compared to other states, you really have to use this Johns Hopkins graph. All right, so let's look at the pipeline for therapeutics and vaccines, because this is new news over the last couple of months. But before I do that, I want to just walk through clinical trials, because that's really what's driving any kind of approval of drugs and vaccines that we're going to see. And for those of you who don't know, prior to phase 1 studies, you have to go through animal studies, all right? So these are human studies here, starting with phase 1, and phase 1 is safety. You do this in a small number of people, looking at the safety of, the drug doesn't even have a name at this point, you know, it might be, you know, MK242 or something. You're looking at safety, and a lot of drugs fall out at this point. They just are not safe. If they're safe enough, they move on to phase 2, where safety and dosing is looked at. So you start looking at more people, and you maybe start looking at different levels of doses to see what is the safest and most effective in this smaller number of people. Once you have a dose that looks good and it still looks safe, you move on to phase 3, which we call our safety and efficacy studies. And these are your very large studies, lots of participants. And in fact, in the vaccine trials that are currently going on for COVID, we are seeing numbers of like 30,000, 40,000, 60,000 participants. So very, very large clinical trials going on there. Once data comes out of phase 3 and it's favorable, it is sent to the FDA for review. And the FDA decides whether or not to approve the drug or vaccine. After that, it continues to be studied in what we call phase 4 or post-approval surveillance, where we continue to monitor for real rare side effects of drugs and vaccines. All right. Now, you've heard recently about emergency use authorizations, or EUAs. The FDA is given power to authorize these during public health emergencies when there's nothing else available. All right, you can't just go and do EUAs just because you want to beat the clock on market approval. There has to be a good reason. And drugs that receive emergency use authorizations still require their effectiveness to be shown in large clinical trials. So they're not done with phase 3 yet. If they get EUA, they might not even be approved once they're done with phase 3. So EUAs are definitely an interim step And unfortunately, one of the downsides of EUAs is that they slow down clinical trial enrollment. So you can imagine that if you are in the hospital and you can request a drug that has EUA, you're going to do that instead of going into a clinical trial where you might get placebo. All right, so it does cause problems as far as finishing up clinical trials. And unfortunately, during COVID, we've seen significant political pressure to authorize EUAs during the pandemic. So what are some therapeutics? Now, these are medications. At the top of the list are the antiviral medications. You've all heard of remdesivir. It is made by Gilead. It stops the virus from replicating, and it literally was approved today. So that's hot off the press news. It is the only drug approved by the FDA for COVID as of today. It is an IV drug given for 5 days. Its cost currently is about $3,000 per that 5-day treatment. It was approved based on 3 clinical trials that showed that the drug reduced recovery time of people hospitalized for COVID by 5 days on average, and 7 days faster in those with severe disease. It also seems to reduce the likelihood of requiring new or more intensive oxygen support, and it's not proven for sure yet, it may reduce the likelihood of death, but it mostly reduces hospital time and the need for more intensive oxygen support. Other medications that are in the antiviral category is favipiravir. This will be the first oral antiviral, so it's different than remdesivir, but it's still awaiting results from clinical trials. And MK-4482 is another oral medication, and it just started its clinical trial. So they're further down the list. Remdesivir is the first one, and it got approval today. There are medications that mimic the immune system, and convalescent plasma is one of those. There was great hope about convalescent plasma earlier in the pandemic. It has been designated by the FDA for an EUA in seriously ill patients, but the data is weak regarding its safety and efficacy. Results from clinical trials show mixed results. And again, unfortunately, it is preventing adequate clinical trial enrollment. This had some political pressure to get its EUA. Interferons are molecules produced by the body to fight viruses because COVID decreases interferons. And so NIH has an ongoing phase 3 trial of a marketed synthetic interferon, Rebif. It's been on the market for a while. It's used in a lot of in immune diseases. Probably the most common one it's used is multiple sclerosis. And they're studying it in combination with remdesivir, and results will be expected in a few months. Other medications that mimic the immune system, ones that everybody's very excited about, are monoclonal antibodies. These are synthetic copies of COVID-19 antibodies. I'll call them MABs. MABs have been approved for over 79 different diseases ranging from cancer to AIDS, so it's not a new methodology. Eli Lilly has an experimental MAB for COVID that reduced the risk of hospitalization by 72% in 450 clinical trial patients. They have applied for EUA designation, and they're waiting on that. And recently a trial studying the combination of remdesivir and this MAB was paused for safety reasons. And Regeneron, of course, you heard all about Regeneron's two MAB cocktail. This has been studied in 275 patients before being given to the president. It also has applied for EUA designation. So the monoclonal antibodies are interesting because they're given to patients to try to prevent hospitalization. It's not to be given to patients in the hospital, it's trying to prevent hospitalization. So we might see EUA designations soon on some of those. Medications that quiet the hyperactive immune system. Dexamethasone is been around for a long time. It's cheap. It's a steroid that's long been used to treat asthma and allergies and inflammation. It has been shown to reduce deaths by 1/5 in COVID-19 patients on oxygen and by 1/3 in ventilator patients. So it's a big hammer in our toolbox for the really sick patients. In clinical trials are cytokine inhibitors. Remember, I talked last time about the cytokine storm that occurs in really seriously ill patients, and blood filtration systems that filter cytokines from the blood. These devices actually received EUA designation, again, political pressure, but now scientific experts have recommended that they be limited to clinical trials because of too many safety concerns. In other words, the EUA may have been given a little too early before results were known of safety. Other common supportive therapies that you see in patients that doctors have come to rely on that help patients in the hospital, might be part of reducing that death rate in hospital patients, is prone positioning. Putting patients on their bellies seems to help avoid the need for ventilators by opening the lungs better. Of course, they use supplemental oxygen by nasal cannula or mask. Ventilators, but those respiratory devices prior to ventilators are being used, like nasal CPAP. Patients are given anticoagulants to try to prevent those common clot formations that we see with COVID. And under study are the immune system benefits of vitamins like vitamin C, D, and zinc. Vaccines. Now, there are over 190 vaccines currently in development. We're not going to talk about all of those. I'm simply going to talk about those under different categories that are literally ready to, that are out there the fastest, that we will probably see as the leading vaccines early next year. The big ones are the genetic vaccines. They're also called the messenger RNA vaccines, and they use COVID virus's genes, its own genes, to produce an antibody response. Now, the issue with these vaccines is that they've never been used before to prevent infections. This is a brand new methodology. It is being developed by Moderna and the NIH. It's currently in phase 3 clinical trials with 30,000 people at 89 United States sites. It will consist of 2 doses separated by 1 month. The good news is it requires normal lab freezer storage. Moderna has put in place nice protocols to test for efficacy. They plan to wait until a certain percentage of volunteers get sick 14 days after the 2nd dose to see whether or not they received the vaccine or placebo. That's how they're going to tell whether or not the vaccine worked, and they're giving it plenty of time. This is one of the vaccines that the United States has plowed a lot of money into funding, $1 billion as part of the Operation Warp Speed program. Another genetic vaccine is Pfizer's vaccine. It's currently in phase 2-3 trials with 43,000 participants. It also has 2 doses separated by 3 weeks. The downside of this vaccine is it requires -94°F freezer storage, and it only lasts 24 hours in a refrigerator, which is going to mean storage is going to be a big problem with this vaccine. It won't be available at your normal everyday lab or clinic. Pfizer plans to wait 7 days after the 2nd dose in order to test efficacy. And the United States awarded almost $2 billion for 100 million doses to be delivered by December, and the option to acquire 500 million more doses. So it's Pfizer and Moderna that are battling for the first approval of this type of vaccine. And you can see if little things like this vaccine is separated by 3 weeks, Moderna is 4 weeks. This vaccine is waiting 7 days after the second dose to test efficacy. Moderna is waiting 14 days. So it's a little faster because you can give the second vaccine faster, and it's a little faster here because they are only waiting 7 days instead of 14 days. It's just unknown which of these two will be approved faster. It's all going to come down to data. You can imagine the pressure coming down on them from the government, especially after putting a lot of money into them to make them go faster. But thankfully, both of these companies have stuck to their guns and said they're going to stick according to protocol and wait to see the data. And that probably won't happen until the end of December, but maybe we'll see a vaccine come out of one of these two in early January. The second type of vaccine is the viral vector vaccine. This uses another virus in order to deliver the coronavirus genes into cells, which then provokes an immune response. This type of methodology has been used successfully to prevent other viral diseases. AstraZeneca has one of the leading viruses. It's a 2-dose vaccine, 1 month apart. United States has awarded lots of money to AstraZeneca for this, though the trial recently went on hold for an adverse safety signal. It restarted again outside of the United States while the FDA continued to study the safety data, but I just saw a couple days ago that it's probably going to start again in the US to get going. These pauses, by the way, are very common in clinical trials. We see this all the time. It's just that it's much more publicized now during COVID with these vaccines and medications. J&J has a viral vector vaccine, a 1-dose vaccine that's in phase 3 with 60,000 participants, but it has been recently paused as well due to a safety signal. And again, the US plowed a lot of money into J&J. So these two will probably be your front runners for this type of vaccine. Then we get to the protein vaccines. These use the viral proteins to evoke an immune response. And these have been used in other vaccines such as the shingles vaccine and hepatitis B. Novavax is the major one here. The US awarded lots of money to support them. They have 10,000 volunteers in phase 3 trials starting this month in the UK, and the US enrollment in even a larger phase 3 trial is expected soon. And they're expected to deliver lots of doses for use in the United States by the first quarter of 2021. And this type of vaccine has many, many other vaccines of this type that are far earlier in the clinical trial process. And then we have the whole virus vaccines. These use weakened or inactivated versions of the virus. And this is the platform that we're used to with flu, chickenpox, mumps, measles, rubella. Now, I'm not sure anybody in the US is doing this vaccine, but there are 2 Chinese pharma companies that have these vaccines in phase 3. Sinopharm finished a phase 3 trial, and they've received emergency use authorization already in the United Arab Emirates for healthcare workers. And Sinovac received an EUA in China, but does expect to distribute to the United States by early 2021. And again, there are many other Chinese and Indian pharma companies that have vaccines in earlier phases. That brings us to the point of the distribution of these vaccines, because it will not be an on-off switch. We're not all going to get a vaccine if we want one, when we want one. The whole supply chain distribution issue will be huge. And certainly we would expect that healthcare workers, first responders, the vulnerable elderly will be first in line to get vaccines, followed by educators, other quote unquote essential workers, adults with pre-existing conditions, institutionalized populations. Tier 3 might be healthy young adults, and they may not happen until 2022. And then finally, adolescents and children, remembering that right now, I think Pfizer might be studying some children. They might have just started a trial to study children, but you can't approve a drug or a vaccine in adolescents and children until it's gone through efficacy and safety trials. So children and adolescents will not be vaccinated for a while. This is that same model I talked about from the University of Washington that I presented last time, but this is one from today. So here you see 16,000 deaths as of October 17th in Florida. They give us a range for by February 1st, anywhere from 25,000 to 36,500 deaths. I say let's assume 28,600 deaths by February 1st, which is still an 80% increase. And every time I present this, I felt the same way when I presented this slide 3 months ago. It takes my breath away and you think, oh, it can't be. It just can't be. But as I say, the modeling has been very good. And of course, remember, we have the holidays coming up, which scares me silly, with what we're going to see with families getting together and without masks around the table and drinking and all that stuff. So it's kind of scary. And the last thing I want to talk about before we end is herd immunity, because you're hearing a lot about that right now. Typically, epidemiologists only talk about herd immunity with respect to vaccines, that we want to reach usually about 70% herd immunity through vaccinations. That is still the case for reputable scientists. But you have people out there right now promoting herd immunity through natural infection. Keep in mind that Florida is currently at 10% immunity based upon serology testing. It has gone up. We were only at 4% in July when I talked to you last, so it has gone up. But trying to achieve natural herd immunity in the United States would mean 180 to 200 million more infections and a conservative 1.8 to 2 million deaths. So this is just bonkers. It's just amazing that people would accept this, but that is what we hear from certain parts of our country. And I just want you to realize that that is not what most scientists and doctors believe. We do want to go for herd immunity, but it's with vaccination, not with natural infections. All right, so in summary, we've learned a lot into 8 months, but we still have a long way to go. And it's still true that basic public health behavior practices are still the best way to prevent illness and severity of illness. So washing hands, masks, social distancing, avoiding the 4 C's. We are all so tired of this virus, but it is not tired of us, unfortunately. So please be careful during the holidays. And as I said, there will be no off and on switch for the end of this crisis. Vaccine distribution and therefore resuming normal life will be a gradual process, and will even after the vaccine comes, will definitely depend on people's comfort levels and what they're comfortable with. And finally, I'd be remiss if I didn't say vote like your life depends on it, because it does, and pray for competent federal and state governments next year to believe in science and lead us out of this crisis. And with that, I will definitely take questions.